So, in our lecture and OT series, now we're going to go to the second leg, and we have a bevy of some really tricky topics for this one.
A very good morning to all of you. I'll be talking about neurogenic bladder. And before I go any further, I will tell you one story. This is a real life story. So one day, a doctor receives a call in his
Yes,
office.
hello.
I am Mr. Ahmed, and urgently I need your consultation. The doctor asks why. He says, because my wife is having severe abdominal pain. It is on the right side more. Sometimes it goes to the umbilicus. I am very concerned. The doctor asked, does she vomit also? He said, yeah, she has vomited twice since morning. And again, she is feeling very nauseous and I want to bring her to hospital. Please do something about her. So the doctor replies that, oh, no worry. I know it is appendix. It is appendicitis. You bring her here, we'll operate on her. So this man says, okay, goes to the hospital and then gets his wife operated. The doctor removes the appendix and the lady is perfectly fine. Next day, both of them very happily, very thankfully go home. Everything is sorted. 1 year later, the doctor receives a call from the same patient or the same man called Ahmed. He calls, he says, doctor, I need an operation for my wife. Can I bring her here? The doctor says, no, you first tell me what is the problem. He says, oh, same problem. Last year I told you, that there is right-sided abdominal pain, nausea, vomiting. She has appendicitis. She needs a surgery. I have to get her to you. So doctor says, no, you bring her. I'll see. I want to do a scan. I want to see what is the problem. He says, no, I know it is appendix. Last time also it happened the same way and it was appendix. He gets really irritated, the doctor, and says that you have to understand one thing. Don't try to become a doctor. We know that, and you also should understand that one human being has only one appendix. It cannot come again and again. So Ahmed says, yeah, I totally understand that one man, one person or one human being can have only one appendix most of the times. But who says that one man cannot have two wives, right? So the perspectives change. When we say that stress urinary incontinence, I keep on teaching everybody, if the patient says that she is leaking on coughing, on exertional activity, most of the times it is stress incontinence. But again, you have to keep your eyes open because perspectives change from person to person from time to time. So keep your eyes open, but mind it. Some patient will enter your OPD with first complaint of neurological problem as urinary symptoms, and you should not miss those problems. We know that if we look at it like this kind of second group which I told you, it will not be majority of your patient. It will be a small slice of the pizza, but you don't know which patient actually is having that kind of problem. So important thing that keep your eyes and mind open always. So there is a very beautiful saying, the day one we enter MBBS, they tell us that eyes can only see what the mind knows. And as you become more and more experienced, you start relating to it more and more that your mind should know for your eyes to see. So before I go any further, I will just very simply, I will tell you the neurogenic control of the bladder or micturition, how it happens. There is spinal cord is also coordinating the bladder as well as the brain is coordinating the bladder. And 99%, this number you remember, 99% of the times, if you understand it, you will realize that the bladder is in relaxed phase. It is in the storage phase. Only 1% of the time in 24 hours, it is voiding or contracting. That 99% of the time, when bladder is relaxed, that you should thank God that the sympathetic system is showing sympathy on us. Will you remember it like that? That we have lot of sympathy of sympathetic system. So for relaxing, which system is important? Sympathetic system. So 99% of the times our bladder is under the control of sympathetic system. When we are voiding, when the bladder is contracting and the sphincter is opening, that is the only 1% of the time when parasympathetic system comes into action. Then, other than this autonomous system, we have sensory and motor supply, which work basically for pelvic floor or the external urethral meatus. Then we have one more thing on the brain. So pontine center has the micturition reflex. It coordinates everything. But again, it is again coordinated, like HOD is again coordinated by Dean. So that gives the inhibitory signal to pontine center so that the patient or a person does not start micturating here and there. So it gives that inhibition that don't micturate here and there, look for the time, look for the place, and then only that inhibition signal goes away. So sympathetic system most important, for voiding parasympathetic system important, to maintaining that social decorum head is important, and this is how. And for somatic supply is pudendal nerve, which actually has motor and sensory, which is for our pelvic floor and external urethral meatus. Now look at this diagram. There are three things, problems can occur in these three phases. The first problem can occur at the level of brain. We call it pontine or suprapontine lesion. In that, just see that other picture on the other side. If that inhibition is lost, brain reflex means the patient is uninhibited now, it will cause overactivity. As soon as the bladder fills, it will not wait for any place or time. It will just empty. So it will be overactive while the urethra is normoactive. So the patient will have a baby kind of bladder. I will come back to it again. Then if this segment, so this upper thoraco, don't have to remember which segment, which nerves, just remember the thoracolumbar region is the sympathetic control. If any lesion is at that level, we know it is a kind of upper motor neuron palsy. And upper motor neuron, what happens? The jerks are exaggerated. Knee jerk is exaggerated. So here, which will be exaggerated? Spasm is exaggerated. So patient will come with overactive bladder, but the problem is here the urethral sphincters also become, everything is overactive. Remember it as upper motor neuron lesion or exaggerated knee jerks, what we see in that condition. Third is sacral or infrasacral lesions. Those are lower motor neuron kind of lesion where everything becomes relaxed. Okay, so there can be two situations in that. One, the bladder is underactive but the urethra is normoactive. The other situation can be that both of them are underactive. So let's discuss how the patients will present in all of those symptoms. I told you again, problem in brain means the inhibition is lost. It is also known as cortical bladder. For you to remember, I have put a baby, so you can remember like the bladder starts acting as if it is an untrained bladder of a child or a baby. This is also called uninhibited bladder, socially disinhibited bladder. It doesn't see what time and place to micturate. But one good thing about this bladder is it is called a safe bladder. Why? Because there is nothing which is, as soon as urine comes, it empties. So nothing, there is no back pressure. So there is no damage to, never there will be any damage to the ureter and kidney. This is also known as safe bladder. How patient will present to you? Patient will say that anywhere, anytime I leak, and usually the amount of leakage is small because little distension, little urine comes out. Okay. Then second, we'll come to the lowermost part. Middle part we'll discuss little later. So in sacral or infrasacral lesions, we call, usually the segments which are involved are S2, 3, 4. I told you parasympathetic system is called urinating nerve. So if that is damaged, means patient will not be having the urge to urinate. Okay, it will be filling but not urinating. This kind of bladder is also, because it is a relaxed bladder, it is called element bladder, and because it is cut off from the upper centers, it is also known as autonomous bladder. What problems patient will have? Because patient is not getting any urge, it has gone into hypotonia. Patient will have voiding problems like retention of urine. When she goes to pass urine, too much pressure she has to apply on her abdomen, poor stream, interrupted stream, and what we call as hesitancy. And if you start looking carefully, many women in your clinic, they might be complaining of this and going from one department to other department without any diagnosis. Then the third part we have to understand is now the middle part, sympathetic system. It is called suprasacral and infrapontine lesion. In this, the bladder becomes automatic bladder and spastic bladder. I have put a picture for you to remember so that it is a knee-jerk kind of similar. Anything happens there, it just goes into spasm. Patient will have problems related to storage here, like urgency and frequency. When the bladder is also overactive and the urethra is overactive, then there is some kind of dyssynergia here. Both are not in sync with each other. We call this pathology as DSD, detrusor sphincter dyssynergia. So patient will have problem, her bladder is filling but she is not able to empty it. Okay, so these two especially, these are different kind of local nerve related injuries also can happen, afflictions to the bladder. So one is when the sensory, pudendal nerve takes sensory as well as motor. So when the sensory supply goes, obviously sensation is not there, so bladder will have painless retention. The other extreme can happen, that is motor paralytic. Again, pudendal motor fibers will go, but this patient, because sensations are intact, when the bladder is filling, patient will have lot of pain. And this problem becomes important for us to recognize because it is usually because of the injury to the nerves during hysterectomy and abdominoperineal surgery. And I will include one more. It can also happen in a difficult or instrumental vaginal delivery where the perineal nerves might get injured or affected. What are the causes? Usually we think that neurological bladder means patient will be lying in one bed, quadriplegic or a stroke patient, but in these 4 or 5 years when we are seeing specifically these patients with urological problems these neurogenic bladder kind of problems, we have seen enough number. Many of them were referred to us, many of them presented as the first symptom. Sometimes we burnt our hands, I'll tell you that also. So all these yellow ones have presented to us in our OPT in one form or the other. Spinal cord injury, that was one of our akkas. Akka means that housekeeping staff's sister who had some mental retardation. She fell down and she had some injury. She slipped in the bathroom. Nobody knew about it, but she came here with sudden urinary retention. We catheterized her, again removed, again retention, again catheterized. Then when we sat down with her and took her history, she has not told it to anybody that actually she fell in the bathroom. She slipped in the bathroom. So when then we sent her to orthopedics, X-ray was done and they immediately, because it was an acute case, they immediately fixed her. Patient became continent again perfectly. So if acute injuries are, please do not ignore that. Patient might be thinking that those two things are unrelated. Who can think that a slip in the bathroom will cause urinary retention? At least it is difficult for a patient to think this. Parkinson's disease, important, very important. I always tell that whenever you talk to patient, ask her name because it will help you to build a rapport. And also add one more thing, shake her hand. It will give the idea of what her tone, muscle tone is. This was a patient, I was holding her hand, she was not leaving my hand. First I thought she has so much love for me. Then I realized it was not love, something was wrong. She was not ready to leave my hands. Then we sent her for neurological evaluation and she was having actually early symptoms of Parkinsonism. Put her on anti-Parkinson's drug and her bladder symptoms improved. Multiple system atrophy can happen. I have not seen it per se. This GB syndrome, interesting. When I was in Germany, in 3 months, I saw 3 cases of GB syndrome who presented with retention of urine as their first complaint. Then later GB syndrome was diagnosed. And I was so surprised. I thought in Germany means maybe GB syndrome happens very frequently. But then I asked my mentor, do you see every month one GB syndrome like that? He told me, no, it's not like that. But I hope you all will agree with me. This keeps on happening, that if you keep 1 or 2 cases like that in that season, those kind of case only will get. Suddenly, when we are getting SUI for 3 months, we'll just get SUI. When we are getting wall prolapse, so I think that was my lucky phase in that way. So they did sacral nerve modulation for her for all 3 patients. Then we get reference of patients who have suffered with stroke for urinary complaints, incontinence. It can be seen in multiple sclerosis, cauda equina syndrome, intervertebral disc prolapse, which is not always because of injury. It can be a part of degenerative process. Again, it can cause urinary complaints. Space occupying lesion. That's what I was telling, that we burnt our hands. We operated. It was a young lady, difficult delivery, and we operated on her. We put TVTO, and second day when removed the catheter, patient did not pass urine. Did not pass urine is okay. We thought maybe the tape is tight. She refused to walk. She did not walk. She was said that first we thought that just she's a little attention seeker kind, but she was not able to walk. She had some kind of paresis in her lower limb. So what happened, that then we gave neurology consultation, and we had done the procedure under spinal anesthesia. So later when MRI was done, she was showing symptoms of all motor and sensory weakness. When her MRI was done, they found out that there was one AV malformation there. And when while they were giving spinal anesthesia, when the pressure became little less because of little leak of that spinal fluid, the symptoms got exaggerated suddenly. So these things also can happen. So space occupying lesion, this was one very demotivating case for us, but we learned a lot here. Then there are radical pelvic surgeries, Fowler syndrome, which is specific to women, medications, and some secondaries. I don't know why I have not put it in yellow, but secondaries, again, malignancies, actually they are somewhere, we find most of them are having neurogenic bladder and causes secondary. Sometimes we only have found out some secondaries prior to anyone else detecting. So I'll quickly finish. There is nothing much if you know the basics. So when we talk about evaluation, always there are only 3 steps: history, examination, and investigation. In history, just one line. Trust your patient what she is saying. Don't think in every patient that maybe something wrong is there. Don't have that kind of feeling. When patient is not able to define things properly in history, when she is giving history of mixed incontinence, when she is not talking coherently, all these things will prompt you towards the diagnosis of maybe that there is a neurogenic bladder. In examination, I have told you before only that shaking hand is very important. And watch her gait. It's not that you tell her to walk from here to there and I'll watch you. That's not important. When she gets up from her chair, goes to lie down on the couch for your examination, please watch her gait. Okay? And then I always tell that very important part, for every examination, I think we should get used to this kind of examination. Whenever either prolapse, incontinence, whatever you are seeing, please check the sensations in the perineal area, anal area, perianal area. Look for clitoral reflex and anal wink. And if you find any problem in any of these conditions, always don't shy to take a neurological opinion. Don't start doing all nervous examination yourself. Send her to neurology. Many of the patients cannot be managed with us alone. We need help. Accept it and send them to neurology for evaluation. Tell the patient you come back and tell me the diagnosis. All evaluation is same almost, but one thing I think uroflowmetry in these cases really help a lot to make the diagnosis. You should do everything, uroflowmetry, cystometry, as well as I think EMG, which tells us about the muscles of the perineum, also has a role in these women. So treatment, simple, treat the cause, relieve the symptoms, and very important that prevent back pressure effect, because some of the lesions will have, when there is retention, the urine might stay in the kidney and patient can have upper urinary tract symptoms, which are even difficult to treat and more dangerous. You might lose a kidney because of that. So to summarize, I just have 3 points. Keep your eyes and mind open when you are evaluating any patient with incontinence. Okay? Bladder symptoms can be the first presenting symptom of underlying neurological pathology. Keep it in mind. And when points are not fitting well together in one straightforward diagnosis, please evaluate her for a neurological cause. I think that's it. Thank you.
So what I've seen now, she has just used 10 slides, okay, and she has spoken for 15 minutes. Okay, so most of the time she was talking and the slides are just running in the background. Not much of information in the slides, but she made us very attentive. And you all know that urogynecology is sometimes I feel it's not that simple. Though we say it's very simple to classify the patient as urge or SUI or it's a mixed incontinence. Better you refer to Dr. Diksha. Okay.
In your practice, ma'am, what is the commonest cause for neurogenic bladder? Maybe you are crossing.
I cannot say commonest because I don't have seen so many patients. Off and on, patient keep on trickling. Maybe when we have a bigger data, we can see.
And thank you very much for your knowledgeable and very elaborative lecture. And give a big applause to Dr. Diksha Pandama.